Good morning, everyone. This is Becky Royer with the Indiana Hospital Association, consultant with the State Office of Rural Health. Just want to welcome everyone today on a wonderfully, hopefully it's sunny where you are. It is where we are. And a fun-filled day for the Critical Access Hospital convening meeting. So if you would like to use your camera, we can encourage you to do that and to join virtually with us throughout the day. I know that we have a few that are in a room together. So if you could maybe chat in who all is in the room with you, why that would be helpful. We like to take an accurate attendance if at all possible. Some of the logistics to go through is that everyone will be on mute today. If you would like to use the chat function, the Indiana Rural Health Association is hosting the Zoom platform for us today. And please chat in if you're having any type of technical issues, and they will be glad to assist you. Likewise, if you do have a question, if you hover at the bottom of the screen beside the chat function, there's a Q&A button. Please click into that, put in your question, and our call convening team will make sure that your question is addressed. There is also a raised hand button at the bottom of the screen. If you press that button and raise your hand, the IRHA team will unmute you and you will be able to ask your questions personally, but please ask questions at any time today. Presentations were emailed out to you on Tuesday from me. That's Becky Royer, and my email address is broyer@IHA Connect. I will put that in the chat function so that if something happened you didn't receive them, I can get them out to you. We also sent a corrected version of the cybersecurity yesterday as well. Each session will be recorded individually today. So after the event, everyone that's registered, we will be able you'll be able to go in and listen to each session individually, and feel free to share those recording links with others in your organization. So at this time, I'm going to turn it over to Karin Kennedy. She's going to start our welcome for us today. Karin?
Yep. Good morning, everyone. Becky, if I could just do a quick check that you can see my slides.
Yes, and you're still in slide deck mode.
Yeah, I'm trying to get it out of that. Oops. A little trouble there. That little button that I'm supposed to push is over my little ribbon that's has all my.
Oh. If you go down through, Karin, we can still see this.
Okay, I'm going to go ahead and go. Okay, in essence of time, I'm going to go ahead and roll with it. So just want to thank all of our hosts for today. This has just been a really great group to work with. We've got a couple departments from the Indiana Department of Health, the Epidemiology Resource Center, the State Office of Rural Health, our partners, the Indiana Rural Health Association and Q-Source, along with the Indiana Hospital Association. And I am Karin Kennedy, and I serve as a Vice President of Quality and Patient Safety at IHA. And again, thank you so much for joining us today virtually. I just want to give a couple of partner updates. First of all, from the Office of Rural Health, they are seeking Critical Access Hospital awards. I won't go through each one of these, but this is just a great opportunity for you to send in an award nomination and get recognized. Those are due for Friday, July 1st by 5 p.m. You'll send those in to David Conrad, who is our state flex coordinator. You'll get these out several different ways. You'll have these in the PowerPoint presentation, plus we'll be sending out reminders throughout now and through July 1st as reminders to get these nominations in. Also, the National Organization of the State Office of Rural Health, they are also seeking their Community Star Award. This is a great opportunity to be recognized nationally. And so I just want to make sure that you're aware that this is also due on Friday, July 1st. This particular nomination will be submitted to Joyce Fillenworth, who is our State Office of Rural Health Manager. So just keep that in mind. We definitely have a lot of community stars here in Indiana. So hopefully we will see a lot of nominations for this one. I know that I personally will be printing this slide off because it's our great team at the Department of Health and the, oh, I just lost my slide deck. Okay. And the great work of Tina Feaster and her team at the Epidemiology Resource Center. So this is the org chart of her team. So just a credible wealth of knowledge here related to healthcare associated infections and antimicrobial resistance. If you haven't joined these webinars, this webinar series regarding healthcare associated infections and antimicrobial resistance, I strongly encourage you to do so. They started back in February. The next one is June 28th. It's part of the project First Line. If you haven't caught these webinars, they are posted on IDOH's website, so you can go back and look at the review the recordings. And also just wanted to let you know, if you're not aware, that IDOH has invested in having infection preventionists throughout the district. So just make sure you're aware of that. And you can get more information on that on the infection prevention webpage. Project First Line for the front line on May 3rd or 4th. That is an upcoming opportunity for you. You can register at firstlinefrontline.com and learn the latest in bacterial and viral transmissions and virus strains and PPE and respirators and much, much more. It's kind of the update from the Indiana Department of Health. I'm going to move on now to the Indiana Rural Health Association. And can you believe that IRHA is celebrating 25 years? Congratulations to IRHA. I think back 25 years ago, I know I was a young professional, and I remember that this organization was starting under the leadership of Frank Shelton. I know he would be very, very proud. I know Tina Elliott has been with the group from day one. So congratulations to IRHA. It'll be a huge celebration at their annual meeting, which will be held as it always is in French Lick, Indiana. So I know I personally am looking forward to being down there. So if you haven't signed up, be sure and go to their website to learn more about that event in June. IRHA does have the IRHA Help, which is connecting people and programs. There is, when you get these slides, you can probably scan it from your screen right now if you have it up, that barcode. To find out the resources available to your community, just a click of your phone, even, or at your desktop. So again, the IRHA conference, I didn't mention the dates, are June 14th and 15th, again at French Lick. The Don Kelso Golf Classic is September 7th. I have not been to that event, but I've heard it's a lot of fun, so take advantage of it. The Upper Midwest Telehealth Resource Center's 4th annual conference is September 13th and 14th, and the welcome reception's the 12th. So and be sure to check out all of IRHA's events on their website, such as their Lunch and Learns. So moving on to the IHA update, this is just a posting of IHA's team and our contact information. Feel free to reach out to us. and take advantage of the great expertise at IHA. We did just recently at IHA release our 2022 Patient Safety Awareness Toolkit. That was part of Patient Safety Awareness Week. But there is lots of resources that you can use throughout the year, because we know that Patient Safety Awareness Week is just not 1 week of the year. It does say toolkit, but actually when you log in, what you will find is that there was like multiple toolkits. There's probably, I think, about 17 different toolkits embedded here with lots of great resources, from leading a culture of safety to increasing patient family engagement, preventing patient harm, and improving community health. So also wanted to put a plug in for those who are birthing hospitals that are joining us today. The 2022 Inspire Hospital of Distinction program is well underway. We will be having that. It does say that we will be celebrating in October of 2022. I did want to just say that we are actually working with IDOH right now to tie that in with the Labor of Love this year. So more will come out with that, but just know that on September 1st, all the documentation is due back to Brittany Wagner at IHA. We also want you to save the date for September 20th at the Embassy Suites for our Patient Safety Summit. Just thrilled that we're going to be able to have that back in person for our Reimagine, Reengage, Rebuild Patient Safety Summit. And this upcoming Tuesday, we are partnering with FSSA to host a Indiana 211, just to provide more awareness to this great program that the state has, folded in. They've taken 211 and now it's part of FSSA. So please join us for that webinar to learn more. QSource, just want to go through that. They are hosting their public updates, public health updates once a month. QSource is also involved with the very important Indiana Healthy Opportunities for People Everywhere, the I Hope initiative. I know IHA is involved with that. IRHA is, as well as IDOH is leading that initiative. And also please take advantage of all the QSource resources as well. So with that, I'm going to turn it over to Cara Veale, who is the President and CEO of the Indiana Rural Health Association, who will be welcoming you. But before I do that, I just want to mention that throughout the day, Brent Anderson, who's the practice coach for IDOH, will be doing some wellness activities with us during the break. So I'm really looking forward to that because we do need to remember to take care of ourselves. And then just want to thank all the hospitals for participating. We do take your feedback. So when you get that survey, let us know what you think of the day, because we do really look at that feedback as we're planning the next one, meeting, which will be in the fall. And we are crossing our fingers that we will be able to do that in person. So without further ado, I'm going to turn it over to you, Cara.
Thank you, Karin. Good morning, everyone. I'm coming to you from Stevenson, Washington, where the sun is not quite up here yet. So it's an early start, but excited to be here with you this morning. So appreciative of our partners at the Indiana Hospital Association and the work they do in preparing the critical access hospital convening meetings. They're always extraordinarily well done, and I'm confident that the content you find today will be very well received and applicable and appropriate for implementation at your individual organizations. So I just want to applaud you all for the work that you've done in navigating the very challenging landscape and the spikes and the hollows of COVID trending, and the way you've responded to both the changes, the ongoing changes with recommendations from the state and the CDC for how we can best take care of our patients, but also how you respond to your individual communities and the patients that you serve. So congratulations to all of you for the strong work that you've done in responding to the pandemic issues. I'm really excited to see the progress and the growth that you all experience over the next several months and years as we sort of learn how to live with COVID-19 and continue to manage it and safely for our patients. So thank you all for being here today. Again, I think you'll find that the content and the agenda for today is very well put together. Thanks again to our partners at IHA. And at this time, I will turn it back over to you, Becky.
Thank you, Cara. And I believe David Conrad has joined. David, are you able to speak now?
I am, if you can hear me.
Yes, thank you.
Sorry about that. Hi, everyone. Sorry I got in late. Had a couple of issues with the Zoom client, but really excited to be here as always. This is always one of my favorite events we put on each year, so I'm just glad that we've got it up and going. And I'm still trying to get myself all sorted out. Apologies. Like I said, it was kind of giving me a few troubles today, but who is it that I'm passing over to next, Becky? Sorry.
Hannah.
Okay. So yeah, thank everyone for being here. I'm going to be here all day if you have any questions and you want to reach out to me. But I will most likely be out because, as you can hear, I've had a nasty cold and allergies all at the same time. So if you have any questions, please feel free to reach out to me, either email or through here. And I'm going to go ahead and pass it over to Hannah.
Thank you, David. So my name is Gallion. I am one of our antimicrobial resistant EPIs here at the Indiana Department of Health. And I have the opportunity today to introduce our first speaker, Pam Pontones. Pam has served at the Indiana State Department of Health for over 30 years. She began her career as a microbiologist in 1990 and transitioned to epidemiology in 1999, serving as the enteric epidemiologist, field epidemiology director, and director of surveillance and investigation. Since 2009, Pam has served as state epidemiologist, overseeing programs including infectious disease epidemiology, syndromic surveillance, data analysis, and public health geographics. And in February 2017, she was appointed Deputy State Health Commissioner, overseeing the Epidemiology Resource Center, Office of Public Health Performance Management, Division of HIV, STD, and Viral Hepatitis, and the newly created Health Issues and Challenges Division. Pam is an adjunct faculty member for the IU Richard M. Fairbanks School of Public Health, and in 2018 was inducted into Delta Omega, the National Honorary Society for Public Health. She was a fellow in the 2001 Mid-America Regional Public Health Leadership Institute, a scholar in the 2010 National Public Health Leadership Institute, and currently a scholar in the 2021-2022 National Preparedness Leadership Institute at Harvard University. She is an active member of the Council of State and Territorial Epidemiologists and serves as the vice chair of the Senior Deputies Committee of the Association of State and Territorial Health Officials. And Pam, we're so thankful that you are able to present today, and I will go ahead and pass it over to you.
Thank you so much, Hannah. I really appreciate your introduction and certainly welcome all of you today. It is my pleasure to speak with all of you. And I'm going to share my screen. Let me make sure that is going to work. Okay, can all of you see my slides?
Yes.
My screen. Perfect. Awesome. Okay, so we'll go ahead and get started. I have a lot of updates to share with you today. And again, thank you so much for inviting me to spend a little bit of time with you this morning, sharing what is happening at IDOH. And certainly appreciate all of our teams here at Indiana Department of Health for the work that they do, and our partners at IHA and IRHA. It's a pleasure, as always, to work with you and partner with you in all of our efforts. So we'll go ahead and get started. So with our COVID-19 response, I wanted to share a little bit of where we are right now with all of you. Right now, as you saw in January, we had the huge Omicron spike that has now really largely bottomed out through February, certainly into March. Now in April, we have just a slight uptick of cases that are overwhelmingly mild. We've not really seen an increase in hospitalizations like we were seeing before. Those are still very low. Deaths, very, very low, not really seeing deaths of any degree to this point. And that really reflects the national trends where there are some increases in some areas of the country in cases due to the BA.2 Omicron variant. Now we have BA.2.12, which is a very close genetic cousin. BA.2 appears to be a little bit more transmissible than the original Omicron strain of BA.1, but not any more severe. And our vaccines, our oral antivirals are very effective against BA.2. Our monoclonal antibodies, with the exception of sotrovimab, are very effective as well. Sotrovimab, not as effective against BA.2, so FDA has pulled that from distribution at this point. But bebtelovimab and Evusheld and the other monoclonal antibodies, again, very effective against BA.2 variant. So because we've really transitioned now post-surge into more of a recovery phase of our response, we have conducted internal and external after action reviews, and we're compiling an improvement plan now based on that information to build, to document, and inform future responses. We are continuing to expand and enhance our data dashboards with streamlined data and new features that I'll show you in just a few minutes. Those are still located on our website at coronavirus.in.gov. With surveillance right now, as I mentioned, case counts low, starting to uptick slightly with no increases in hospitalizations or deaths. Cases really being in the younger adult, maybe the 18 to 29 year age groups. BA.2 variant dominant, starting to see BA.2.12 now starting to appear as well. But our surveillance will continue, and we conduct surveillance to monitor burden of cases, monitor where we might be seeing any increased severity or any increased hotspots in the state through different surveillance tools that we use. Cases are still reportable by clinicians and laboratories that are conducting molecular testing. Syndromic surveillance using our emergency department chief complaint data that we receive, as well as any school closure data, which we aren't seeing, which is great. Genomic or sequencing surveillance, very important for us to monitor the appearance of any variants or any changes that we are seeing. And we are in process right now of onboarding wastewater surveillance. We look to have that. We have been working with the CDC contractual program with a handful of wastewater treatment plants here in Indiana, but we are looking to onboard that technology shortly here at our State Department of Health laboratory, and we have quite a number of wastewater treatment plants now in the queue to onboard very shortly. What's unique about wastewater is that it's what we call a leading indicator, and that we know that SARS-CoV-2, the virus that causes COVID-19, can be shed in stool, which does end up in wastewater. And we can, what studies have shown and what we've seen through other cities across the country and with CDC is that you can start to see the appearance of virus in wastewater about 4 to 6 days before you start to see the correlative increase in cases that are being reported. So that can give us a little bit of a heads up when we might start to see increases in cases of COVID-19. What we have done right now as we move from more of the crisis response phase of the pandemic is to develop what we call the planning now for the next phase of the pandemic. So we've embarked on what we call the right on track plan for the next phase, more the recovery phase of the pandemic, applying all that we've learned in the past 2 years. During the pandemic, more crisis response to help keep Indiana on track and prepare for future health emergencies. And while we're using our Right on Track plan really for the COVID-19 preparedness and readiness, really these tools can be applied to the preparation and readiness for response to any large-scale communicable disease outbreak. The first part of the Right on Track plan, and we have an acronym because that's what we do. We like our acronyms. The T in track stands for testing and treatment, making sure that we have enough over-the-counter COVID-19 tests to schools and to local health departments. We've been sending those out across our state. Expanding access to treatment options, including monoclonal antibody treatments for infusions, as well as oral antivirals such as molnupiravir and Paxlovid. We're continuing the expansion of locations that offer oral antivirals and continuing to make sure that we have Evusheld, the pre-exposure prophylaxis monoclonal antibody, available as well. We're also ensuring that long-term care facilities have access to treatment from their pharmacies and long-term and local partners, including retail pharmacies and hospitals, and educating healthcare providers and the public on the availability of treatment options and locations. We still have our treatment map available on the COVID or coronavirus.in.gov website that shows the availability of monoclonal antibody infusion sites, as well as partners that are supplying oral antivirals. The R in the TRACK acronym stands for readiness. In that vein, we are developing and maintaining an Indiana stockpile of personal protective equipment, or PPE, vaccines, and testing supplies that we can deploy to areas of the state that may be experiencing an increase in COVID-19 cases that we see through our surveillance. We're promoting an all hazards approach to preparedness, including readiness for the next pandemic, the next natural disaster, or even potential terrorism. So again, using the Right on Track plan for a variety of responses that we may have in the future. We're updating our preparedness and response plans, again, based on the lessons learned from COVID-19 and considerations for the next pandemic. Last night, I just finished reviewing our after action report and improvement plan, and we hope to start embarking on those tasks and action items here soon. The A in TRACK stands for awareness. Such as implementing our updated, accessible, and mobile-friendly data dashboards, which I will show you here in a couple of minutes, with additional features to track community spread and variants. And also want to point out that anyone at any time can also access the CDC community levels by going to www.cdc.gov, clicking on community level, you enter your county and your state, and the system will show you exactly where the burden of COVID-19 is for your particular county and what the corresponding control measures are. Those three levels are low, medium, and high based on the cases per 100,000, the number of new hospital admissions in the past 7 days, and the number of hospital beds in use for patients with COVID-19 in the past 7 days. Fortunately, as of this week, all of Indiana counties are in the low community level, and the recommended control measures are, first of all, to be always up to date with all recommended doses of COVID-19 vaccine, and to be sure to get tested if you develop symptoms of COVID-19 or if you have been exposed. We also inform and enable Hoosiers as part of our awareness to be consumers of information regarding COVID-19 in their communities and how they can protect themselves, corresponding with the CDC community levels, which you can now find linked on our website. We have enhanced functions and features to monitor levels and burden of COVID-19 in the community through coordination of local and state recovery efforts. The C in TRACK stands for community resilience and countermeasures, really focusing on and eliminating health inequities between communities regarding race, ethnicity, age, geography, urban and rural, and other social determinants of health. We've seen, you all have seen, where the COVID-19 pandemic has really exacerbated some long-standing health inequities and shone that light on them to where we really need to make that concerted effort to eliminate those. We want to include our primary proven countermeasures to prevent severe illness and hospitalization, that being vaccine. So we continue to offer vaccine, to promote vaccine, and follow the latest recommendations with the FDA and the CDC. I saw just this morning the news headlines where now Moderna has now requested emergency use authorization of its vaccine for kids below age 18. So including 6 months up to 5 years, 12 to 17, and 5 to 12 years of age. So check that out if you haven't already seen it. That was just this morning. We continue to advocate for mitigation measures for those most at risk of severe disease progress and death, including our aging populations, the immunocompromised, making sure that they have clear and ready access to vaccines, to preventive therapeutics, to treatment therapeutics as much as possible. And we continue engagement with our communities to address vaccine hesitancy and concerns and identify needs that communities may have. Lastly, but certainly not least, the K in TRAC stands for kids. Promoting in-person learning environments in schools and early childhood learning centers, and excellence in healthy behaviors such as hand washing, respiratory etiquette, staying home when you're sick. Sustaining collaborative partnerships between the Indiana Department of Health and the Indiana Department of Education and the Family and Social Services Administration for our early childhood learning centers. Encouraging continued partnerships between local health departments, schools, and early childhood learning centers to make sure that they have what they need and that there is robust communication and points of contact if schools, early childhood learning centers notice any increase in cases. Providing at-home testing capabilities to schools. We have distributed at-home tests through different schools that wanted to participate for students to take home, literally in their backpacks, and have at home available should students develop symptoms or become exposed to COVID-19. And then finally, and so important, to support catch-up routine immunizations and screening efforts in the summer and fall of this year. We know that kids have fallen behind in routine childhood immunizations as a result of the pandemic, that some of the routine screenings, such as hearing, vision, lead screenings that they might have received have also fallen behind due to the pandemic. So we are using our Department of Health operated mobile units to augment local capacity for administration of routine immunizations and providing support to schools to offer those preventive health screenings that might have been delayed during the pandemic. So lots happening to keep on that path as we move toward recovery, but also that ever-present readiness for the next main public health event. For our surge planning, I've talked about some of this, ensuring adequate supplies of personal protective equipment, including procedural masks, NIOSH approved respirators are readily available. And what we mean by that is at least a 10-week supply within our stockpile. Ensuring adequate testing supplies are readily available, and including a method to anticipate or calculate daily PPE usage or burn rates and any significant changes that may occur should we see another surge, especially as we head into the fall. Ensuring compliance with infection control procedures, including updated staffing trainings, and ensuring and promoting COVID-19 mitigation and control measures, which you can still see posted at the link on your slide. We want to make sure that you all have emergency plans in place now. So local health departments, hospitals, primary care providers, long-term care facilities, and other congregate settings, take this time right now while activity is low to update your emergency plans, to consider what may happen in the fall should we see another surge. Now is the time. We also want to ensure, as part of our surge planning, compliance with reporting requirements. The state and federal reporting through EM Resource or teletracking or the National Health Safety Network. Federal therapeutics reporting is still being done via the HPAP platform. And we want to make sure that we maintain access to therapeutics for both staff and patients of our hospitals, our long-term care facilities, and other medical settings, as well as continuing equitable access to vaccines for all Hoosiers across our state. We continue here at the Department of Health to have free PPE and testing supplies available to order through Langham Logistics. So please check out the link at your slide to order additional supplies. I mentioned some dashboard updates and wanted to share some screenshots of those with you. We will be adding more updates in the coming weeks. Notice that all of the information now fits neatly into one screen if we look at our vaccination dashboard or our case dashboard. And when you pull up the coronavirus.in.gov and you go to the dashboard tab, you will see all of the dashboards now on one page that you can just click on various tabs, whether I want to look at youth dashboard or vaccination dashboard or case dashboard, so that you don't have to keep scrolling down through pages. You see updated vaccination information, as well as what the reinfection rates are, breakthrough infections, breakthrough deaths, and hospitalizations as well. So we will continue to modify those. And our at-a-glance dashboard now is going to be offering more comprehensive county level data, so that county level leadership will have a snapshot of their county's most relevant data, including cases, vaccinations, and demographic data in one place that you can select through drop-down menus. So I'd like to shift gears a little bit from COVID-19 and talk about where we are in Indiana with sexually transmitted diseases, mainly because, unfortunately, we are seeing significant increases of STDs across our state. When we take a look at data over the past couple of years, we see that cases of syphilis have more than doubled among women over the past 5 years, and we know that is a significant issue for congenital syphilis as well. Proportionally among men, syphilis has increased most among heterosexual men in the past 5 years, an increase of 75%. Over the last decade, we've seen that we have now reported we've been reporting an average of 4 cases of congenital syphilis per year over the past 10 years. However, for 2021, preliminary data shows that we now have 20 reported congenital syphilis cases. So a 5-fold increase of the yearly total that we've seen over the past decade. In addition, we've seen that with gonorrhea, we have by race and in the figure that you see here, total number of gonorrhea cases in 2020 broken down by patient race, that we see a significant proportion in the Black and African American population. This disparity is not seen among other STDs like chlamydia and adult syphilis, but really seems to be more specific to gonorrhea. Since younger Black patients are disproportionately affected by gonorrhea, that disease is becoming more difficult, and it is a disease now that is becoming more difficult to treat. It's so important to ensure their access to care and that they are frequently assessed and attempt to remove any barriers that we have that would prevent them from acquiring comprehensive sexual health care. We are seeing significant challenges now with antibiotic resistance with gonorrhea. And in some cases, we have only one now recommended antibiotic treatment regimen left before we move into more of a total antibiotic resistant situation. So we are really trying to curb those new infections and make sure that individuals and their partners have prompt access to care and treatment. Syphilis is also making a historic change. Historically speaking, syphilis is seen mainly among men, especially men who have sex with other men. And we do see that continuing to be the case in Indiana as of 2020, which is the year for which we have a most recent year for which we have complete data. However, there has been increasing number of syphilis infections among heterosexual men and women over the last 5 years, and that is being mirrored at the national level as well. As I mentioned, very unfortunately, congenital syphilis cases continue to increase in Indiana. And as of April 19th of 2022, we already have 10 probable congenital syphilis cases reported. So far, that is 10, or I'm sorry, that 10 is 50% of the entire year that we saw for 2021 when I mentioned 20. We see 5 of those cases from Marion County, but the fact that it's the end of April and we've already reached 50% of the cases that we had all of last year is very concerning. That unfortunately mirrors also what we're seeing at the national level. CDC recently released their preliminary 2021 Std Surveillance report, and nationally we continue to see that increase in congenital syphilis cases as well, up 6% nationally in 2021, with 33 states reporting increases in congenital syphilis cases. We also see early 2021 data show an increase in primary and secondary syphilis among adults, a 34% increase in women, 9% increase in men. So again, seeing those significant increases in women, which again is not a good sign for the increase in congenital syphilis cases as well. I also wanted to share with you where we are in the continuum of HIV care in the all of last year through January through December of 2021. We have made some great strides in our care continuum of people living with HIV. So when we look at HIV prevalence, we're talking about all persons in the state living with HIV/AIDS. Linked to care means the people are individuals based on their CD4 or viral load levels within the past 30 days of diagnosis. So the viral load and the CD4 cell count indicating the need for linkage to care, and the goal being within 30 days of diagnosis. Retained in care based on the CD4 cell count and viral load within the past 12 months. Same with the suppressed viral load based on the most recent CD4 cell count or viral load within the past 12 months. And those having an unmet need defined on having no reported CD4 or viral load within the past 12 months. And what we are happy to see, and we continue to make additional strides, is that of persons living with HIV/AIDS, 76% were retained in care in 2021, over 72%. We had a 68% viral suppression rate, which is an increase of 4% from 2020. We had 84% linked to care within 30 days in 2021. And you can see more about the national levels shown at the link on your slide, or the reference shown on your slide to the recent MMWR publication. So this just shows you additionally that kind of that increase in syphilis in Indiana, as well as the counties that have been impacted with pregnant females with syphilis and potential congenital syphilis cases. We're really seeing that this is shown throughout the state. We do have some hotspots in terms of our counties with higher population, but we really see where this is not just localized to one particular area of the state, which is why we feel it's so important to make sure that clinicians, hospital partners, our care partners are aware of these trends. I also wanted to share some information with you about the latest in pediatric hepatitis that you may have heard about. We've had some states across the country now, Alabama, we've heard Wisconsin, Illinois, seeing increasing numbers of children in emergency departments being hospitalized with hepatitis symptoms, and liver injury or failure, who have no underlying conditions or immunocompromised. Many of them being under the age of 10, median age about 2 years, 78% female among the 9 cases that have been identified in Alabama. 67% were Hispanic. Some had co-infections, but not the same co-infections, and none were found to be related to COVID-19. All of the 9 Alabama cases tested positive for adenovirus by RT-PCR testing of whole blood, and 5 of those tested positive for adenotype 41. There appears at this point to be no epi-link among any of the cases, and other countries, especially in Europe, have seen similar increases in cases, such as the UK and Spain. CDC issued a health alert network message on April 21st, which we reflexed out to our partners as well. There is a webinar today with CDC at 4 o'clock for more information on case definitions and some of the epidemiologic description of these cases. And we do ask any of our partners, providers, hospitals, local health departments who hear of these cases to please contact the Epidemiology Resource Center here at the Indiana Department of Health at 317-233-7125. I also wanted to share a little bit about where we are with changes in elevated blood lead levels. The Indiana Department of Health is planning to lower the elevated blood lead level threshold on July 1 from 10 micrograms per deciliter to 3.5. So that means that children having lower levels of lead exposure will be directed to get confirmatory testing, either via a capillary or venous blood draw. Venous blood draw is preferred. If a child's initial capillary test comes back at or above 3.5, they should get a confirmatory test. If that level is above 5, they are referred for case management at the local health department. In this past legislative session, the state legislature passed HEA 1313, requiring providers to offer lead screening testing to all children, now effective starting January 1 of 2023. If a child, any child, has a primary health care provider, that provider should be helping the child get tested at 12 months and at 24 months of age. If a child doesn't have a primary healthcare provider, any provider then seeing the child should be helping the parent or guardian get that child tested. We will have additional guidance on that legislation and coming out in the next few months. Providers with limited or no prior exposure to a lead poisoned child who don't know where to turn for clinical support can contact the Indiana Poison Control Center or our Region 5 Pediatric Environmental Health Specialty Unit. You can also contact Paul Krebins at our Indiana Department of Health Lead and Healthy Homes Division. Our My Healthy Baby initiative, what we formerly called our OB Navigator program, continues to roll out across our state. We are very excited about its progress. This is a cross-agency initiative between the Indiana Department of Health, Family and Social Services Administration, and the Department of Child Services, with the goal being to connect pregnant women insured by Medicaid with a local family support provider as early as possible in their pregnancies. And when we say successful contact, we mean that we were able to have a full conversation with that pregnant mom. She's had the chance to accept or decline referral to a navigator. And women who have this conversation with us accept a referral over half the time. So it is worthwhile. The challenge that we're working on now is how to make more contact with more women. And you can see as of April 22nd, some of the success that we have had. You can find out more information about My Healthy Baby at the link shown on your slide. Our launch schedule continues. We completed a launch in 22 counties in blue in 2020. So despite the pandemic, we were making strides with My Healthy Baby. We completed rollout to 25 counties additionally in 2021. Our goal is to roll out to 35 additional counties this year, kind of the reddish pink here in 2022, with the remaining 10 counties in purple next year in 2023. This link that you see here on your slide leads to a very simple referral form that takes less than 5 minutes to complete. So if you have patients who could use pregnancy guidance and support, we ask that you do provide this link to them and refer them to this program. I also wanted to make note of our Health Issues and Challenges grant program that has launched on January 27th, and we have rolling now very well. In early last year, last summer, I believe it was, the General Assembly appropriated $50 million of America Rescue Plan Act funds to the Indiana Department of Health through House Enrolled Act 1007 to address several challenging health issues that historically have been issues in Indiana, including chronic disease, hepatitis C, food insecurity and obesity, tobacco use cessation, elevated blood lead levels, and disease prevention, including community paramedicine and community health workers and patient navigators. We launched this funding opportunity on January 7th. It did conclude on March 31st, and we are currently reviewing all those applications that we received, totaling 215. We're very excited about that. We had a few requirements for grantees to include proposed, measurable, and specific improvement in one or more of those areas, the impact their proposal would have on health equity in their communities, and how they would sustain that effort past the grant period. As I mentioned, we received 215 applications representing about 167 entities, and we are continuing to review those applications according to a standard scoring rubric through the end of this week. We will be issuing award letters in May, with contracts for funding being issued by July 1. Funds must be encumbered by the end of 2024 and spent by the end of 2026. And so everything that I've talked about so far this morning relates to our new state health assessment and state health improvement plan that we released in February for the 2022-2026 timeframe. We now have an executive summary posted on our website, and our full report is under final review and will be posted shortly. We certainly want to thank all of our partner organizations, including IRHA and IHA, who participated in the creation of this roadmap for Indiana health. And I want to highlight that this is truly an Indiana plan. It is not an Indiana Department of Health plan, but an Indiana roadmap to better health for Hoosiers over the next 5 years. The highlights of the health improvement plan, which was informed by data in the state health assessment, include a description of the Governor's Public Health Commission, state health data, both overall and by public health district, including community engagement data, community partner assessments, and community context assessments. State health improvement priorities with objectives, strategies, and metrics, and then our list of partner organizations and a resource page. Our health priorities for the next 5 years include improving health outcomes and risk factors, mental health and wellness, family, women, infants, and children, healthy aging, public health systems and workforce, including infrastructure, and social determinants of health. The goals of the Indiana Health Improvement Plan are to increase Hoosiers' access to care, improving communication and education within the public health system, providing those tangible supports to the workforce that are needed, promoting preventive care and overall health to Hoosiers, bolstering community connections and the built environment, and expanding our public health infrastructure capacity. So all of this aligning very well with our Governor's Public Health Commission work streams and priorities also. So that is what I have for you this morning. I'll go ahead and stop there and take any questions that you may have.
Wow, Pam, that was really a great presentation with a lot of good information. We do have a couple of questions. The first question is, I just had a 6-year-old pediatric hepatitis, or a 6-year-old with hepatitis that we transferred. What is the survival rate for these kids?
So there across the country, and certainly here in Indiana, but across the country, there have been no confirmed deaths at this point related to the pediatric hepatitis that is being seen. Several have been, I think probably all of them have been hospitalized. There have been some reportedly, I think 2 in Alabama requiring liver transplants. At least at this point, and still hearing that that might be the case now with other states. But at this point, no confirmed deaths that have been reported. However, it is vitally important that these kids do receive adequate supportive care, and these kids are pretty sick. We did issue the CDC Health Alert Network messaging, and do encourage clinicians to read that and to make sure that we can get these kids tested, that we're ruling out viral hepatitis A through E. We are testing for adenovirus, some of those testing recommendations at this point. So any clinicians that think that they have pediatric patients with this hepatitis syndrome, please contact the Indiana Department of Health Epidemiology Resource Center at 317-233-7125.
Thank you, Pam. And again, you can ask questions through the Q&A function, or you can enter them into chat. We do have another question in chat. From Linda Webb, great presentation. Do you know how long we will need to do EM resource?
That is a fantastic question. We still are continuing to do that. I'm not sure of an end date at this point, but I can certainly find out. I would go ahead and keep reporting into that. And I can find out more about an end date and send that information to folks there at the conference today.
Okay, thank you. Likewise, if you want to ask a question personally, you can press raise your hand and the IRHA staff will unmute your line and you can ask a question directly. There was one other question related to the health issues and challenge grants. Will that deadline potentially be extended to submit for any of those grants?
That is a great question, and it is possible. We are reviewing the grants that we've received, the applications that we have received right now, and looking at where those grants fall versus how much money has been appropriated. And if we find that we can accommodate, then we are considering offering a second round of application availability.
Okay, thank you. We'll be watching to see if there is an extension then. So I know there's lots of people thinking about different ideas. The next question that came in is, and this is in regard to COVID, are you expecting any differences in the frequency for boosters for the different age groups?
That is a great question and really to be determined. That is really under consideration right now with FDA, with CDC, discussions being held in terms of what that booster framework might look like, especially as we get closer to the fall. So considering what age groups, considering the frequency and interval of boosters, considering if booster formulation may need to be different, depending on what variant might be circulating, if it's still Omicron or an Omicron subvariant. Currently, Pfizer and Moderna both are working on Omicron-specific boosters. There is also, I believe, development underway on a COVID flu combination vaccine. So lots being done right now in the booster vaccine space to anticipate how that might look. So my short answer is stay tuned, because there is a lot happening in terms of how that's going to shake out. I anticipate we're going to hear more probably, I would say, in June-ish, and keep watching for the FDA press releases to see what's going to be requested for emergency use authorization, what those schedules might be that the CDC Advisory Council on Immunization Practices may recommend. So as soon as we get more information, we will be sure to share that on webinars with local health departments, with QSource. I'm happy to get back on a call with all of you and provide that information. We also would send that through our Indiana Health Alert Network messaging as well.
Perfect, thank you. The last question that was sent directly to me was, do you have an estimation on the COVID rates with a number of hospital or a number of home tests that are being conducted that are positive? So I think their question is, those positive home tests that aren't reported, is there an estimation on the impact it has on the actual rates?
There is not. That is a good question, and one that's been asked at the national level on national calls. And we don't have really a number in terms of a firm level of impact that is having on overall case rates. But what's important to remember is that to really know what our trends are and our overall burden, we don't need to count every single case. And in fact, during the entire pandemic, we knew we weren't counting every single case. Even before at-home tests became available, we knew that there were folks who were asymptomatic who weren't getting tested, or people who were sick who weren't getting tested, or providers who may not have had testing. So we knew we weren't capturing every case. But what is important to note is that cases are still reportable by providers that are ordering testing, PCR testing. Laboratories are still required to report their PCR test results. So while we get maybe not every case, we do have solid numbers on positive cases to be able to detect trends. And that's really what we want to see, is what are the trends doing? Are they going up? Are they going down? Have they bottomed out? Are we seeing different variants? And that's what our different surveillance streams will allow us to do.
Thank you.
I would recommend, though, certainly the availability of at-home tests is out there, readily available. People should have a supply in their home so that if someone does develop symptoms or they've been exposed, they have ready access to testing, whether that's ordering online or purchasing at a local pharmacy. Really important. One question that I get a lot is, well, I have seasonal allergies, or I think I have a cold. How do I know if it's COVID? The answer is still get tested. And now with the availability of home tests, that access is even broader.
Thank you. Don or Kathy, did you have any questions come directly to you?
I did not, Becky. No.
Okay. Kathy?
I did not.
Okay. Hannah, any questions come your way?
I did not get any.
Okay. All right. Well, thank you so much, Pam. We really appreciate it.
You're very
Great
welcome.
information and great